Morning. Hello and welcome. Hope everybody is well this morning. I am looking forward to today's discussion. For those of you who I haven't had an opportunity to meet before, I am Matthew Hart, the CEO for Longwoods Publishing and the producers of this event. That's it for me. I would now like to hand things over to Catherine Gaulton, the CEO for HIROC. Catherine, all yours.
Good morning, and thanks very much, Matt. And thank you to Longwoods for hosting us for this important conversation. Thank all of you for attending. I know how very busy your days are now, always are, but particularly now. And thank you for your interest. HIROC's really pleased to be part of this work. I'll quickly pass this over to Feben to provide us with both the context for how racism and other diversity, equity, inclusion, and belonging shortcomings affect quality and safety, and to describe for us the AOM's wonderful work on how this shows itself for one group of healthcare professionals, midwives, in their care environment. I'll say HIROC is admittedly early days in its work in relation to how these issues address claims. We know from the literature and research, including Feben's work, that DEIB issues have an adverse impact on quality and safety. Our subscribers tell us that. Our subscribers are increasingly looking at ways that they can consider this issue as they do quality reviews, and therefore how the recommendations that come out of those reviews are reflective of what needs to happen to truly make a difference. And so we know this is very much an issue on our main vision, which is, of course, partnering to create the safest healthcare system. We do not, however, in our program, have definitive data on how this impacts claims. We know it's there. We know that it is frequent, that these issues are frequently the context for claims, but there is still work to be done by HIROC and by our system generally in this regard, and we will be working on this. So part of the piece with this is to really accentuate the voice that speaks to this as a significant issue for quality and safety, and we believe in claims. We are increasingly looking at and working with partners and our subscribers in particular about how we appropriately code so that we can identify these issues and really do get to more data in this regard. We are increasing our attention on how diversity, equity, inclusion, and belonging factors arise in how we provide risk advice. What is the context for that advice? And so really, again, in a very much a learning environment, but acknowledging the need to ensure that our advice reflects these issues. Most importantly, we are partnering with our own subscribers who are doing great work in this area. Feben and the Association of Ontario Midwives are a wonderful example of this. We will and are very much listening to what our subscribers are doing. And we know that they are instrumental in making the change that the system needs on these issues. We will be and intend to be very instrumental in ensuring that we share learnings among our subscribers. I am amazed by the work we see, and our ability to share it will be, we believe, one of the most important things that we do at HIROC. To this end, and to learnings from subscribers and thinking about how we can best make recommendations and the change that is required in this regard, it's my great pleasure to pass this to Feben, Aseffa, and so that she can describe the wonderful work that she's been doing and really to sort of set some context for us in relation to this issue. Feben is ever practical, and so we'll actually also get to some of the work that we can start to think about and some of the actions that we can start to take in order to advance this. And so over to Feben. Thank you, Feben. Thank you to all of you.
Thank you, Catherine, and thank you, Matt, and thank you all for being present here today and for providing me the opportunity to speak with you about the impacts of systemic racism on healthcare quality and safety. Well, as a registered midwife, much of my work focuses on perinatal care, but of course, systemic racism, unfortunately, is widespread across the healthcare system. And much of what we will discuss today with regards to our work at the Association of Ontario Midwives to understand the various ways racism manifests and our thought processes and prioritizing actions to address racism are, I'm hoping you find would be transferable across the healthcare sector and across your organizations. So I hope our discussion today would provide you some useful takeaways to continue building on work that you may already be doing within your organization. And I would love, as Matt mentioned, to hear about some of the initiatives taking place in your respective institutions. And so, we'll hold space at the end, and I really do welcome and invite just candid discussions. Next slide, please. So before we jump into discussions around how to work towards dismantling systemic racism, I want to ensure that we're using a common language and have a common understanding of what we mean when referring to systemic racism within healthcare. And unlike interpersonal racism, which refers to assumptions, biases, or beliefs that an individual may hold, systemic racism refers to the practices or policies that are part of the structures of an organization and which create or perpetuate inequity and disadvantage people because of their race, culture, creed, or ethnic origin. And although race is a social construct, having no biological basis, racism is embedded in all aspects of our society, including our justice system, government, education, employment, and healthcare systems, and of course, day-to-day interactions. So we've basically become accustomed to living with racism. However, its impacts affect us all differently. But the key thing to understand is that it indeed affects us all. See, racism is not just a problem for racialized people, it's a problem for all, racialized and white folks, because we cannot live with racism without it affecting our humanity to some degree. But we're here today to talk about its impacts within the healthcare system specifically. And we know from countless data, be it mainly in the US and UK, since we are lagging behind on race data in Canada, that racism can lead to adverse health outcomes, reduced care satisfaction for patients. It can reduce sense of psychological safety and attrition of racialized healthcare workers, and it can also impact an organization's reputation and risk of liability. So the data is clear. Racism is a real problem in our healthcare system and a crisis, some would argue, and it warrants urgent and an immediate action. But we know this already. So why aren't we allocating adequate resources to address this real and urgent problem? And as you can imagine, the simple answer is it's complicated. And it is. When we have disparities in a complex system, such as our healthcare system, intersecting with a complex problem, such as racism, the solution is nothing short of complex. And any intervention to dismantle systemic racism needs to be systemic and systematic, and it needs to be top-down and have a multi-pronged approach. Next slide, please. So before we get into interventions to address this problem, I'd like to share some stats that illustrate a compelling case as to why we need to act now. So these are mainly perinatal stats, since this is the area of my work. But since systemic racism and inequities are present across the healthcare system, again, hopefully you'll feel this is relevant. And as I mentioned earlier, we have limited race and equity data in Canada, but some organizations such as the Black Health Alliance, for example, have collected race data. And much of this data points to the significant health disparities Black and Indigenous people face. Studies have shown that racialized women are more likely to experience discrimination and bias in the healthcare system. And this experience of discrimination and bias can cause stress and trauma, which can negatively impact physical and mental health. Now, when we talk about racism, we need to understand racism as a structural determinant of health. So in other words, we cannot address racism without addressing the societal norms and institutional policies and practices that create barriers and perpetuate harm and inequity towards racialized and minoritized groups. And if we're to meaningfully address structural racism, we need to understand and target our efforts in dismantling anti-Indigenous and anti-Black racism, because the statistics of adverse outcomes for Indigenous and Black communities in particular are sadly abysmal. On this slide, I have a few stats highlighting some of the disparate health outcomes. I won't read all of these bullets, but want to draw your attention to the last bullet. It's a 2015 meta-analysis of hundreds of studies between 1983 and 2013, which looked at the relationship between racism and mental and physical health outcomes and confirmed that racism is indeed a determinant of health. This meta-analysis found that even when factoring for age, sex, birthplace, and education levels, this did not moderate the effects of racism on health outcomes. So in other words, one's age, sex, birthplace, and education level were not protective against racism. I'm happy to share any of these studies if people are interested after the presentation, by the way. And there's another study published actually just very recently, a couple of weeks ago, I believe, which looked at more than 1.5 million inpatient procedures and found that Black patients are 42% more likely to die 30 days after surgery compared to white patients. The authors project that even a mere 2% reduction in excess mortality rates of Black patients can avert roughly 3,000 post-surgery deaths over the next 10 years. That's a number to really sit on. And yes, some of these patients may have had poor health prior to surgery, and this can increase the risk of adverse outcomes, but it's undeniable that racism in our healthcare systems and society at large play a significant role in one's health status. And some of these deaths could have been avoided had disparities been eliminated. Now, we know that culturally appropriate, we know that culturally appropriate care and awareness of systemic issues that predispose some communities to chronic diseases are critical to providing quality care. So for example, people of African descent are genetically predisposed to diabetes, but the root cause is not their race or ethnicity. It is related to social determinants of health, including lived experience of systemic racism, distrust of the health system, higher rates of poverty, and isolation, to name a few. Thus, a whole person perspective is necessary to provide anti-racist healthcare services. Now, as I mentioned earlier, because of the dearth of Canadian studies investigating racism, we do lean quite heavily on studies south of the border. Thanks, Matt. And a common argument to dismiss US stats from being used here in Canada is the notion that differences in health insurance coverage and access to care play a role in worsening maternal and infant health outcomes. And although this is partially true, inequities and broader social and economic factors and structural and systemic racism and discrimination are actually the primary drivers for disparate maternal and infant health outcomes among Indigenous, Black, and racialized communities. So in other words, disparities in maternal and infant health persist even when controlling for certain underlying social and economic factors, such as education and income, pointing to the roles systemic racism and discrimination play in driving these disparities. Next slide, please. So we've discussed why systemic racism is a problem. Let's move to actions we can take to address the problem. So there are many models that provide frameworks to lead organizational change. And Cotter's model is just one that some of you, may be familiar with, and one that I've leaned on or referred to in developing our change strategy at my organization. This model outlines 8 steps for transformative organizational change, and I'll walk you through these steps to share some of my thinking and planning at our organization in leading some of this change strategy. So the first step in Cotter's model is establishing a sense of urgency. And this is particularly important when addressing systemic racism, since we have data showing the disparate health outcomes resulting from racism and health inequity. So it's critical to address any fears or aversions people may have for change and impress on workers that the status quo is simply not sustainable. And then in the next step, we have building a guiding coalition of people with shared commitment and power influence to lead change efforts. And this could include building departmental equity leads or a change team comprised of people with racial and professional diversity and having intersecting lived experiences to bring diverse worldviews and skill sets to this change effort. And ensuring that this change team is actually representative of the diverse patient and staff population is also helpful in garnering support or at least minimizing resistance to the change efforts. And then next, we have creating a vision and developing a strategy to bring about change. Anti-racism and health equity should be a strategic priority, and commitments to dismantle systemic racism should be embedded in your organization's mission, vision, values, and strategic plan. And these commitments should have measurable goals that you will work towards and be accountable to. And then next, we have communicating the vision clearly and consistently, because it's critical to ensuring support and buy-in. And this should be communicated with staff across all levels, with patients and clients, and certain stakeholders in the public to a certain extent. And obviously, this communication will vary depending on the audience. And then next, we have empowering others to act on vision. So you want to consider the barriers and facilitators that may prevent or enable people to action organizational commitments and vision. Because systemic racism is so deeply rooted in the structures and processes of our organizations, to make meaningful change, we need to be prepared to unlearn and relearn new systems that are intentionally designed to dismantle racism, just as our current systems were intentionally engineered to create the inequity that we have today. And then next is generating short-term goals. Although dismantling systemic racism requires long-term visioning, you don't undo, 400 or 500 years of racism within a year or two. But in order to boost morale and maintain urgency for change, it's important to also create short-term goals with visible, measurable wins. This also is useful to track and quantify performance and outcomes and to measure against set KPIs. And then next, you have sustaining the vision by capitalizing on wins or gains to produce bigger results. When dismantling systemic racism is the vision you're working towards, learning from your successes and challenges to make improvements and leveraging the credibility you've gained from early wins can help to drive more change by building capacity and expanding the scope. And then finally, in this Cotter's model, we have institutionalized new approaches. So develop a framework to monitor and evaluate progress and measure against benchmarks to ensure that you are on target and to make adjustments or to course correct as needed. And this monitoring and evaluation framework should not be static. It should evolve as the scope expands and the KPIs change to reflect your new targets. Next slide, please. So let's now move into what implementing frameworks such as Cotter's model actually looks like. So I'll share some of the thinking and actions we took at the Association of Ontario Midwives to present sort of a case example of our intervention strategy to address systemic racism. And as you can imagine, such efforts require a comprehensive and holistic approach that involves the entire organization and all of its systems. So this slide provides a template action plan that the healthcare organizations, other organizations can adapt and implement. Obviously, these steps will need to be individualized to meet the needs of your local context. And as much as it's important to base interventions on evidence-based processes, I really want to implore all of you to not delay taking action until you have all the evidence, and thereby making perfect the enemy of good. And a reminder that, when we think about what is evidence, evidence can be research studies and publications or curricula that we're taught through institutionalized learning, but it's also empirical knowledge, the lived experience, observations, and worldviews of Indigenous, Black, and people of color, and the diverse communities that we serve. So let's not get too hung up on a specific type of evidence and dismiss other forms of knowledge. So starting from the top left quadrant, collecting and analyzing data on the demographics of your patient or client population and the health disparities they're experiencing is essential to identify areas for improvement and to provide culturally responsive care. This also allows us to identify who is most marginalized and how this marginalization is presenting. Since providing equal care to all is not health equity. Rather, health equity requires the delivery of care that is responsive to the specific needs of the communities experiencing disparities. And likewise, it's also important to understand the demographics of your staff or healthcare workers at all levels of the organization, particularly looking at leadership levels in order to gain better representation within those leadership positions. We also need to understand the experiences of all staff and healthcare workers with regards to psychological safety at work, their needs, their job satisfaction, any barriers or disparities when it comes to recruitment, promotion, and retention, to ensure that we create work environments that not only attract talent from diverse backgrounds, but are safe and equitable for all staff, regardless of their race, culture, creed, ethnicity, gender, sexual orientation, and all other code-protected grounds. And so moving to the next quadrant, increasing accountability, this requires making health equity and anti-racism a strategic priority. And I'm not referring to simply incorporating these words into organizational position statements and web pages and social media posts, but actually making a commitment to dismantle systemic racism and embedding these commitments into the organization's mission, vision, values, and strategic plan with clear, measurable goals that you will work towards and be accountable to. So implementing the vision and organizational commitments also requires adequate allocation of resources. Now, values and commitments must be reflected in the budget, because values without a dollar amount are just simply not valuable. So an example is at the AUM, we reviewed and updated our strategic plan to ensure that equity and racial justice were not just an isolated pillar. Rather, we had a pillar dedicated to achieving this and ensured that equity and anti-racism principles were embedded across all of our strategic goals and commitments. We also reviewed our bylaws through an anti-racism lens to ensure that these foundational documents are in line with our strategic commitments to equity and racial justice. And another element of organizational accountability is to look at the policies and procedures in place that perpetuate systemic racism and inequity. And as part of our organizational accountability, we also reviewed our policies and procedures, including our human resource and governance policies using an anti-racism framework. It's important to develop policies and protocols to mitigate and address racism and to ensure that staff have the competencies to operationalize these policies. And this means staff and healthcare workers needs to receive ongoing training and tools to increase their awareness and understanding of the impacts of racism on health outcomes and to mitigate its occurrence and be equipped to action change. And if anyone is interested to see our strategic goal and objectives that I spoke to, or our any specific frameworks that we used to action some of our racial equity commitments, I'd be happy to share these offline. Matt will share the contacts at the end. And then next we have reorganizing power and strengthening relationships. Engaging in community outreach and partnership building involves collaborating with community-based organizations and advocacy groups to build relationships and partnerships that will improve the safety and quality of care provided to marginalized communities. Now, appropriate engagement with members of the community that would be most impacted by the work or who can inform or direct the work is a critical aspect of change management initiatives. So the organization could consider, for example, creating an EDI committee that is led by IPOC individuals, and sorry, by IPOC, I mean Indigenous, Black, and people of color, without, of course, the burden of operationalizing the work falling on IPOC members, rather where non-IPOC members are accountable for doing the work under the leadership of IPOC members with lived experience and expertise. This consultation and collaboration is essential to ensure that any actions that are taken by the organization actually meet the needs of the communities they will impact, and thereby upholding the adage, nothing about us without us. Another important step is to review your governance processes and leadership structures in your organization. The goal here is to commit to move beyond simply increasing diversity during recruitment efforts, but instead recognizing IPOC excellence and removing barriers to IPOC staff obtaining leadership roles. There are numerous opportunities to facilitate IPOC leadership and professional growth. For example, consider tapping folks on the shoulder to ask if they would be interested in a leadership role and provide professional development or mentorship opportunities to support this. And remember, having diversity in leadership is not just a benefit to the individual in that role, but the organization as a whole, since diversity and talent and perspectives at all levels, but particularly in decision-making tables, allows us to move beyond groupthink and can bring new and innovative thinking into our organizations. And needless to say, recruitment efforts for leaders with a strong understanding of anti-racism principles is important to ensure that an anti-racism lens is consistently applied across the organization. Then the next quadrant, we have evaluate and monitor. Evaluating and monitoring the interventions implemented are critical steps that sometimes get overlooked because organizations are just very busy doing the work, and pausing to measure the effects of the work can sometimes get derailed. So we need to be intentional about the interventions that we institute and have an understanding of how we're going to measure success, what our KPIs are, and then measure progress against these benchmarks. Evaluation and monitoring are ongoing processes and will require us to course correct as needed, and will also support organizations to lead with accountability and responsiveness, and hopefully to make the impactful change that we seek to make. And again, these intervention strategies are just examples that I wanted to share from our work over the past few years. I'm hoping that some of these points might be of use to others, as they can be tailored to meet the needs of your local context. And as you know, changing organizational culture and dismantling racism is a journey, not a destination, and it requires building trust, which can't be rushed. It must be earned. Next slide, please. Thank you. So to wrap up, I'll just close with this slide to say that if we're not looking for the problem, we won't see the problem. It's imperative that we thoroughly investigate how racism is impacting the health outcomes of our patients or clients and the working conditions of our healthcare workers and staff. So the key message that I'm hoping you take away from today's presentation is that each of us has a role to play in challenging inequity and oppression and racism. And sometimes we use our voice or spheres of influence to impact change. Other times we amplify the voices of others or stand back and hold space for individuals with lived experience to take the lead, should they want to, of course, never expecting them to. But the important thing is that we start the work today. And remember that you don't have to have all the answers, nor should you delay starting out of fear of making a mistake, because quite frankly, you will make a mistake. We all do, but we will own them. And then we will continue moving forward to make some improvements, because some improvements are just better than the status quo. And that's it from my part of the presentation. I wanted to leave ample time for discussions, questions, and just really, as we mentioned earlier, to just even here, we have a very large group with people from across the healthcare sector. It would be really helpful to hear, what are some of the challenges you've experienced in trying to, do this work? What are some of the successes that you've had? And really, this is a place to just share experiences, I think, and ask questions if there are any. And yeah.
Hi, and so Feben, thank you very much for this. I really, before we get to questions, and there's some great ones that I think most of them are for you, Feben, so I'll ask, read them for you, but and read them for the audience. I think, the issues around resistance, or for whatever pieces we may use to say that this is not an imperative to act right now, or of course, increasingly not tenable given the data that we have. And I thank you and the AOM for your transparency in relation to the work that you're doing within the system generally, and certainly within Ontario Midwifery. A couple of questions. There was an initial question that I answered, which really is the messaging around using acronyms, and that I used DEIB. And that, of course, is diversity, equity, inclusion, and belonging. I think the last letter gets changed depending on where you are, but it's really that notion of how people feel that they operate within an environment and are acknowledged within an environment. The first question, Feben, is whether this work that you are referencing, whether it was a Canadian study.
Muted. This never ends, does it? It's just to be clear, when you see the work that I did reference several studies in here, and there's a reference list for those studies. Those mainly were US, but if you're referring, if the person asking the question is referring to maybe work, I'm not sure if I referred to our own study that we conducted at the AUM. I don't think I did in this presentation, but the studies that I have on this slide, for instance, they're all in the references, with the exception of the most recent study that I just mentioned, which was the higher rates of death post-surgery. That one I will attach, because that study I just pulled through more last minute.
Yeah, and Feben, I think the question seemed to appear when you were referencing that study, so I think it was
okay.
the one.
Okay.
Though I can't say for sure, of course.
Yeah.
Questions in, but that one is also an American study. Is that correct?
It was, yes, it is an American study. That's correct.
Okay. All right. Thank you for that. We have lots of great questions coming. So the next one is really about so many hospitals do not make it easy to do this work because there are no requirements from bodies like HIROC that require a DEI strategy. Will HIROC considering embedding this as a requirement? Also, why is Canadian data required to do this work when we do not collect desegregated data? We know the disparities exist. And Feben, I'll ask the latter part of that question to you. I think, and I certainly can't speak for other bodies. HIROC's role is, of course, as an insurer. We're not a standard setting body. And having said that, we do not shy away from our obligation as an organization that deals and supports and is supported by healthcare organizations in the country and healthcare professionals in the country. And so our work will really be around looking at the data that we have, the data that our subscribers have, ensuring that it is shared. And so not to have requirements. We have a limited ability to do that, but by really bringing the message forward and not remotely to shy away from the obligation that we all have in relation to this really crucial quality and safety work. Feben, just on the topic of why is Canadian data required when we actually don't collect it? So a bit of a failing game, and so I don't know if there's anything you want to say on that front.
Yeah, I mean, required is, here's the thing, right? Like, yes, we should strive to understand, like, collecting data and understanding what understanding what the experiences of patients and workers are with regards to racism is one piece. But I wouldn't say we should hold ourselves to requiring the data before we start actioning the work, because you're absolutely correct. We know that the disparities exist. So are we going to allow people to, lose their lives or experience adverse outcomes of whatever degree while we are waiting to collect data? Absolutely not. And I think we can sort of do both, where we work to put in place the actions that we know can intervene now in the moment, while we also work to improve. One of the challenges is the comparators, like, you want to use the Stats Canada data, for instance, as a comparator would be a great comparator to work with, because you can then do some comparison across the region. But we know that that data set is not perfect either. There are flaws. And so this is really where, I was speaking with, don't wait till you have all the evidence in place, or where perfect is the enemy of good. start the work. You can work on the data aspect, but I think the key piece is we do have enough information to show us where we can start intervening and making some change. I don't know if that answers the question about the, required to have data.
Thanks, Feben. There are lots of questions in the chat in the question and answer section on the collection of data, and I think the next question was really about your views around the Canadian hesitancy around collecting race data. The person asking the question is leading that change at their organization to begin to collect data and to understand whether there is a gap in service, and they've met with resistance around privacy concerns, for example. And so how is it that we're going to move past that? And I think another question is, can you speak to the data collection methods that you've used? So whether there's anything you want to add on both how you've worked and what has worked well for you, and how to perhaps get past some of the resistance, particularly if it's being presented as privacy concerns and that kind of thing. If there's anything you want to add.
Okay, so I hope I did grasp everything well. There's quite a bit in this question.
There is, yeah. So let me make it. So one is around your own data collection methods and how that worked well. And then the second question is around how you might get past some of the hesitancy around data collection in relation to racism, particularly if it's being raised as a privacy concern. So sorry, two parts to that.
Yeah, no, fair. And so because the Association of Ontario Midwives is member facing, we're not actually collecting data from patients, because collecting data from practitioners or healthcare workers is very different from collecting data from patients in terms of even vulnerability and, like many other aspects. And so we collected data from our members, Ontario Midwives, and there was a lot of thought put into that, like even just being very intentional about and really working through and creating to be able to justify, why are we collecting certain information? Because when we talk about the importance of collecting data, we really want to think about what is the purpose that we're collecting this data? What are we going to do about this information? Because you need to be also accountable as having to be able to justify why you're collecting that data and what you're doing with it, as much as it's nice to have a whole lot of data when you're collecting sensitive data to be able to rationalize it. And so we made a decision that we were going to collect specific equity data, but not all, because we knew that we weren't able to really action on all items. But when we're talking about collecting from patients or client population, there needs to be, again, that same intentional accountability to, what are you doing with the data that you're collecting? Of course, I hope everybody's familiar with like OCAP principles and the likes. When you are collecting, especially data from Indigenous populations, there is frameworks such as like the EGAP framework that you could use. I will share some of those links for people to read more about OCAP and EGAP, for instance, around data collection. But and then you need to also ensure that those who are collecting data and then interacting with the patients or client population have education to be able to engage in a culturally sensitive and safe manner, because obviously a lot of that fear from sharing data is how will this data be used? And quite frankly, our experiences has been that when data has been collected, it hasn't really benefited people. In fact, sometimes it harms people. So for those of us that are responsible for collecting data, analyzing the data, and therefore engaging with the communities that you've collected data from, really having good training and education around the way data has been collected in a harmful way. How do you not inadvertently do that as well? And being able to communicate clearly with the communities that you're collecting data from, you know, how you'll be accountable to this and what measures you're taking so that this data is not used in a harmful manner. I think that is really one of the biggest fear of resistance from many communities in terms of sharing data. And of course, it's never mandatory, right? You're always providing people an option to opt out of any sort of questionnaire process that is collecting data. But there's so much around collecting data that we first must need to understand. And so as much as throughout the presentation, we talked about the importance of collecting data, when we are collecting sensitive equity related data, though, there's really a lot of work we have to do to understand the harms potentially and the risks. Was there another aspect of the question, Catherine, that I might have missed?
No, I think that's very very well done, and I, you know, and look, I think the history, unfortunately, and maybe we run scared of our own history, is that with, as Feben said, when this data was collected, the notion that it in fact increased the number of human rights abuses as opposed to was used for useful purposes. Is the history that we need to come away from. There are some fantastic examples of how to do this well in jurisdictions that have thought through the issues, have been very clear about the reason, and Feben's focus on that is absolutely crucial. Feben, lots of other questions coming through. I think if I can, questions about that leaders and maybe healthcare providers generally do not understand systemic racism and how it is embedded in healthcare. Maybe many think we are nice, so we must not be racist. How is it that you engage leaders who either cannot see it or are blind to what's there? And I think it's the question about, and I think you've done some fantastic work on this at AOM, about really increasing awareness, increasing it as a leadership imperative in your organization. And so just, I wonder if you could speak to those questions.
Yeah, engaging leaders. And it's absolutely true. I think in many instances, you find people who might be very strong advocates to social justice broadly, right? They have good intentions, and therefore it's like, how could I be racist? And I think therein lies the problem, especially as leaders or in organizations. The question is never, you know, are we racist, or is there racism in our organization? And I think it's really starting with, that's not the question. The question is, yes, there's racism in our organization, or yes, because of the, you know, the waters we swim in, the environment that we're in, we inherently are racist, but what do we do about it? That's the question, right? And so you can have good intentions, but those good intentions could still lead to, like, could still harm individuals. A culture of, we just need to really listen and relearn. And it doesn't mean we're bad. You see, it's when we start putting this dichotomy of like good versus bad. You're racist, therefore you're bad. You're not racist, therefore you're good. That's not the place that we want to start having conversations. It's just, this is what structural racism is, and what do we do about it? And I think really just coming from that humble place of just listening, pausing and listening, and that's what I would encourage folks to invite leaders to do, is just start from the place of listening. But it's also why it's really important, when I was mentioning earlier, to look at our leadership tables and seeing, you know, do we have a diversity of perspectives? Do we have a diversity of worldviews and lived experiences? Because then that really does allow for, you know, conversations that are rich and varied.
Yeah, thanks, Feben. There's a question of whether you could give some examples of systemic racism in the health system, and it comes from this lens. The questioner is identifying the trouble or the potential issue in differentiating racist systems versus individuals in positions of power who demonstrate or promote racist or non-equitable practices. Are they the same?
Sorry, can give examples of systemic. I'm trying to find the question. I'm scrolling through.
Yeah, no.
Follow,
So
but
Can you give some examples of systemic racism in the health system?
Mhm.
And the questioner is indicating they have trouble differentiating racist systems from situations where individuals in positions of power are demonstrating or promoting racism or other non-equitable practices. So the interface, I think, between what is racist and what is the system of inequities generally.
Right. So, for instance, like one example, if an individual in your organization experiences racism, be it interpersonal racism or whatever, you know, we look at systems as in what are the policies and procedures in your organization. For instance, that's an example of a systems issues that could be worked on. So do you have a policy that speaks to how you can file a complaint if there is an experience of racism? And is that policy very clear with helping people who are responsible for receiving that complaint to understand, you know, like how to respond, what appropriate course of actions are, what the organization's accountability will be? Or is it some, you know, or do you use generic language such as you're going to encourage the people to have, you know, to come together and, you know, have a conversation as a first step if you can. And then you're going to go to step, you know, the second step and the third step and the fourth step in a very generic way? Or does it truly understand what, you know, harms of racism could look like and what sorts of supports the person might require, and what sort of actions would be needed to you know, to provide corrective measures or whatever. So looking at those policies, and to be honest, oftentimes, you know, we'd find that it's easy to say we have zero tolerance, or, you know, we don't, whatever, these are the commitments or values of the organization. But what does actioning it look like? And do people who then have this policy, do they really, you know, feel safe to come forward with certain experiences? And so I think that's where, you know, you're not looking at the individual, at the interpersonal level, but you're looking at addressing the systems level, right?
Yeah.
I don't know if that
Feben,
provides
I
an
think,
example.
you know, I thought, at least for me, and maybe this is helpful for the person asking the question too, your data around the impacts in relation to on healthcare and on health outcomes, based on through a lens of what the impact of racism is, particularly it are some of the studies, and we'll make them available. But I think the work around that, even when you control for other inequities, you know, so for socioeconomic inequities, for example, that you still see race as one of the defining factors in relation to health outcomes. So I think that work of the differentiation between what might be a general concern around inequities is, of course, really relevant and needs to be addressed. But even with that, with the layering of the control for those, some of the studies that Feben was presenting, I think might be helpful. There are set and wonderful to have so many questions. This is exactly what Feben and certainly HIROC had wanted to generate, was this discussion. And, you know, and Feben, I think one of the questions really raises this issue around, there's this whole work that you do in relation to what are health professionals and people who are working in organizations feeling as they interact and as they work in the healthcare system and in related entities. And then it's, how is it that we're actually also trying to decide on particular people, patient population. So if you're a health region, for example, you know, how is it that you're identifying the priority for that patient population? And I'll just say, it's agreed that this is extremely hard work to get to. There are, you know, some organizations that are doing work on this. No one would say that they have perfection in this regard. I'll just tell you, you know, in HIROC's own experience, we did a specific survey in relation to diversity, equity, inclusion, and belonging. it's difficult. Then you get data and you say, well, what does it actually mean? And then to be able to probe what it means so that you can take appropriate action to address it is an additional really difficult area, so as not to in fact cause trauma in the digging, for lack of a better word. So I think really difficult to do this work well, and some work that's been done in other areas. One of the questioners points out that there is some federal data in relation to race that is collected, and racism, but how it is impacting healthcare is maybe something that we haven't quite captured, and probably will be an ongoing process in any event. For everyone on, Matt's very helpfully going to share the questions with us, and together with Feben and with Longwoods, we will, to the extent that there are additional materials that we haven't referenced here, that Feben has such a huge number of in her work, that we will share those with the participants in the session afterwards. But and apologies for not getting to all of the questions, though I think we did cover hopefully most of them. Feben, I don't know if there's anything you want to say finally before we pass it back to Matt, but I do want to thank everyone for attending today, and for participating with us in this hugely important conversation. But Feben, anything for you before we hand it back to Matt?
Yeah, no, thank you, Catherine, and thank you, Matt, and everyone. And yes, I definitely would be happy to as I said earlier, engage offline and address some of those questions that we didn't get a chance to get to. So thank you all.